Thank you very much for inviting me. So I've got half an hour just to run through a topic which, as we already know, is very close to the hearts of some people here. And I know that many of you will know colleagues who've died by suicide, and they may be people who are also in your family, as we know. So some of the issues in this presentation might be quite hard, but my intention is to have an optimistic message, because if we understand the phenomenon of suicide bereavement, we can begin to think about appropriate responses. And so this presentation has been put together in the light of Rosie's article she wrote, it's actually the pinned tweet at the top of her Twitter feed, but it was a web article she wrote for veterinary wellbeing, supporting practices after a suicide. So I would encourage you all to read that. So I'm going to talk a little bit about the extent of exposure in the general population, and then I'm going to run through the latest research evidence which describes the impact of suicide on people in relation to their mental health and also their social functioning. And I'm going to focus a little bit on specific issues for vets and then think about how we might pull this information together and think about an appropriate response. So what is this scale of suicide loss? Now, the statistic that we often see from the World Health Organization is that 800,000 people die by suicide every year. Now, if we think specifically about the veterinary profession, we've got evidence on the left here from the US, and we know that over the period 1979 to 2015, 398 vets died by suicide. And if we take into account the denominator, we can see that the suicide rate for vets was indeed greater than that for the general population over that time period. Now turning to the UK, we had a recent Office for National Statistics publication, which was published in 2017, and that analysed suicide rates by professional group. And we could see that over that period, which was 2011 to 2015, there were 15 vets who died by suicide and 6 veterinary nurses. And I'm sure that many of you here will know who some of those individuals were. But I suppose what was reassuring about this report was that it found that suicide rates amongst vets was in fact the same as for the general population. So that in itself is reassuring. But of course, you know, that there is a changing picture. So in the previous period, from 1991 to 2000, ONS published figures in 2009 which showed that vets were indeed one of those high-risk groups. And you may remember a lot of media attention at that time focused on farmers, doctors, dentists, nurses, and vets. And in fact, in the most recent period, the specific groups at risk are very different. The focus is very much now on construction workers, skilled agricultural and construction roles, people who work in culture, media, and sport, which is quite surprising, and also carers who work in a paid caring role, as well as female teachers. But of course, we're waiting for the next tranche of figures, and that may well change again, and there's no reason to be complacent about the figures in relation to the veterinary profession. So how many people are exposed to each suicide death? And by that I mean people in the immediate social networks of the person who died who will have been affected emotionally by that person's death. Now, there are a huge range of figures that have been suggested over the years, and I've expressed them along this continuum. So at the far end, we have a figure of 6, which was a complete guess, which was produced by somebody called Schneidman, who was one of the early academic researchers in the field of suicide bereavement, and he came up with a figure of 6, which I understand from going to a conference last week was based on the number of people who would gain from an insurance claim, I think. Anyway, it was a complete guess. And later, WHO came up with a figure of 5 to 10, which was again a guess. And then people started to do some academic research on this, and they did social network analysis, and they came up, for example, with a figure of 60 people, which is 20 relatives, 20 friends, 20 colleagues, and I think most of us can relate to that. Other figures, of which are much higher, 135 people, 425 people, these are extrapolations, and I think, as you can imagine, represent more peripheral social contacts. But when somebody dies by suicide, even if you didn't know them very well, it might have particular resonance for you because it might remind you of somebody else in your network who's died by suicide, perhaps using the same method. So one can't dismiss people in the peripheral social network as people who are not affected and not in need of support. We've also got some figures for how many people in the population are affected. So a recent systematic review by a Belgian colleague, Carl Andreasen, he pooled data from numerous reports and found a past year exposure of 4%. So in the previous year, 4% of the population knew someone who died by suicide. But when you look at lifetime exposure, the figure was 22. Now, since then, 2 other studies have been published, which had estimates which were much higher for lifetime exposure, and they were 51% for a recent American study and 58% for a recent Australian study, and they were asking people in the general population, have you ever known someone who's died by suicide? So the general message is that it's very common to have known someone who died by suicide, and we know that from listening to the presentations this morning that the many people the many people who know of people in veterinary practice who've died by suicide and how wide the exposure is within those settings where there have historically been high suicide rates. And of course, we have our family networks, which can be quite small. In some families, they can be wider in others. But actually, there is academic research studying social networks which shows that actually exposure at work can be much greater than at home. And there was a Swedish study which looked at social network size in the workplace and came up with a mean of 15 people that people knew in their workplaces socially and professionally. And that was contrasted with only an average network size of 2.9 in the home. So you can see that a suicide in somebody who works with a large number of people can potentially have a much wider public health impact than it might do within their families. So in this next section, I'm just going to run through the research which describes the impact of suicide bereavement. And as you're looking at these slides, I want you to think about in the future when you're back at work, if there is a colleague of yours who is affected by suicide, or indeed there is a suicide within your professional network, that you're thinking about these issues when you're looking at your colleagues and thinking about who might be in particular need of support, because these are the kind of things to look out for. So first of all, there is an increased risk of suicide in people who are bereaved by the suicide of a relative and also of a partner. So we're talking about both genetic risk and non-genetic risk. So we know, and we have done for many years, that suicide risk runs in families. But the references I've put up here relate not only to families, the study by Tidmalm on the left, but also this Danish study by Annette Langsen on the right, which looked at spouses bereaved by suicide. Now, obviously, this is not looking at colleagues bereaved by suicide, but often vets tend to partner up with other vets. So obviously, this is highly relevant for the people here. It also increases mortality by any cause, and we don't know whether that's due to things like increased substance misuse after a suicide, not having someone around who's attending to one's kind of physical health. So those are possible explanations for the increase in mortality by all causes. We've also done work here in the UK which showed that approximately 9% of people bereaved by suicide go on to make a suicide attempt, and that's in relatives and non-relatives. And that was a national study sampling people who worked and studied in universities, and that also included RVC, as well as my own university, UCL. So some back-of-the-envelope calculations there in relation to our findings on the risk of suicide attempt. If we take WHO's figure of 800,000 people who die by suicide a year, and we use that kind of conservative estimate in the middle of my continuum of 60 people who are affected by each suicide, so that would suggest that about 48 million people are bereaved by suicide annually. And if you take that figure of 9% of people who go on to make a suicide attempt, then we're talking about 4.32 million people who enter the pool of at-risk people for suicide attempt each year. So when we're thinking about the public health burden, I think that's really quite substantial. So moving on to other negative health impacts of suicide bereavement. So a lot of work from national registry-based studies. So these are very good quality studies which are not affected by response bias or sampling bias. Find an increased risk of post-traumatic stress disorder, and I think that often relates to the trauma of suicide loss, the horror of perhaps of the method used, and particularly when somebody actually finds the body of the person that they know. There's also an increased risk of mood disorders, psychotic disorders, personality disorder, and that will most likely affect people who are bereaved at a younger age as their personality is still crystallizing. And also it increases the risk of psychiatric admission, and I certainly see that on my psychiatric ward where we have patients who have been bereaved by suicide and are very, very preoccupied by the method used by the person that they knew and loved. I mentioned physical health problems in relation to the increased risk of all-cause mortality, and this Danish study found an increased risk of cancer, sleep disorders, respiratory disorders, and spinal disc herniation when you compare people bereaved by suicide with people in the general population. Now, when they compared people bereaved by suicide with people bereaved by other non-suicide bereavements, they found an increased risk of all-cause mortality, but a reduction in risk in certain specific illnesses. And I confess I have no idea why this is to be the case. And it's possible, when you think about these studies where you're looking at multiple outcomes, it's possible that some of these findings are purely due to chance. Now, we've heard about complicated grief being a particular problem in people bereaved by suicide, but what's interesting is when you compare people bereaved by different causes, there's certainly an increased risk of complicated grief in people who've experienced bereavement due to a violent loss, and that might include accidental death or suicide, but it isn't actually specific to suicide loss. But I've mentioned it here because amongst people who are bereaved by suicide, the people who score higher on the inventory of complicated grief will have a higher risk of suicidal ideation, thinking about suicide, making plans to take one's life. So I think it is relevant here. Studies which measure constructs of grief, so stigma, shame, responsibility, guilt, these also find that people bereaved by suicide have elevated scores on all these domains. And when you think about losing a colleague to suicide, it's easy to imagine how people can wonder what they could have done to prevent that loss, how they could have been a better colleague or friend, thinking about maybe time when they passed work on to their colleague and feeling bad about the extra pressure that put on their friend and colleague. So it's easy to see how these kind of grief measures might be worse after a suicide loss. There are also a range of adverse social outcomes after a suicide loss. So again, Danish evidence shows that spouses bereaved by suicide are more likely to have to claim benefits. Parents bereaved by suicide in this Canadian study by Bolton et al., parents were more likely to break up after the suicide of their child compared to parents bereaved by the motor vehicle crash death of their child. Generally, in our UK survey, we found that people bereaved by suicide had lower scores in terms of social functioning, and they were more likely than people bereaved by accidental death or sudden natural causes to drop out of their courses, to drop out of their jobs. So when we're thinking about students in veterinary college who are making suicide attempts or even dying by suicide, the impact on their peers includes potentially also dropping out of university and further down the line, dropping out of their veterinary practice. And we heard from Rosie about the problems of retention in veterinary medicine. Our survey also showed that people bereaved by suicide perceive real deficits in the support from family and friends. And again, we heard from Rosie how important informal support is. But it seems that after a suicide loss, there's something that's so difficult to communicate in terms of offering support that often people bereaved by suicide say, I didn't get any support from anybody. And immediately after the death, there was just this long, long hiatus before anybody felt able to come forward and offer support. And that is felt very, very acutely. And we did an interview study, not nearly as many interviews as Rosie has conducted, but we did 27 interviews with people bereaved by suicide. There were 13 people who'd been bereaved by suicide, and there are about equal numbers of people who'd been bereaved by sudden accidental death and sudden natural causes. And we wanted to ask them about their experiences of other people's reactions to them, because we talk about stigma, but sometimes it's quite hard to operationalize what it actually means. And what was striking was that all three groups described feeling very, very stigmatized after their sudden bereavement, but it was couched very much in terms of other people being very socially awkward. So the topic of death or having to broach this issue and say, I'm really sorry about the death of your partner or your friend, were just too difficult for the largely British people in this study to address. And where the people bereaved by suicide stood out was that mentioning the word suicide was a complete shock factor. So if somebody, was making a new friendship and they were being asked about their family and, where do your folks live? And they said, well, my mum lives in, Perthshire, but my dad died by suicide when I was 14. There's, so it has a real shock factor. The conversation is shut down, they move on, and their experiences of feeling very stigmatized. And what was particularly characteristic of the people bereaved by suicide was getting absolutely no support after the loss, and that's, very, very concerning. Now, what's even more concerning is this slide, which summarizes the trial evidence out there for interventions that are specifically designed to support people bereaved by suicide, and that's known as postvention, the idea that the support you offer after a suicide will actually limit the potential ripple effect through the social network of further suicide attempts, of further psychiatric morbidity. So I've put together findings here from 4 systematic reviews, and there's only really one study in all this body of literature which actually looks at suicide-related outcomes. So this US study by Stanley Zissuk et al. At the top was a complicated grief therapy for people who reached a certain threshold in terms of complicated grief, and this was found to reduce suicidal ideation. But there's only one other study which purports to look at suicidal grief, but when you actually look at the outcome they used, it wasn't what I would call suicidal grief. It was aspects of grief which didn't relate to any sort of suicidal construct at all. So even though these interventions do have evidence of reducing anxiety and depression, reducing grief intensity, and in reducing the blame that people feel after a suicide loss. So they do have benefits, and you could hypothesize that by reducing the risk of depression and anxiety, you might go some way. Sorry, wrong slide, thank you, Chair. So I've been gesticulating to this slide at the top, Stanley Zissuk. So that was the study that did show a reduction in suicidal ideation, but it's this study here which I wouldn't regard as having an impact on suicide-related outcomes, and these studies at the bottom which did show good outcomes, and you could hypothesize, as I said, that these might go in some way to reducing longer-term suicide risk, but in the relatively short time frames that they were looking at in these studies, they didn't reduce suicide attempts. And I think it doesn't necessarily mean that all of these interventions are a waste of time. I think we need better quality trials, longer term follow-up to really understand what is beneficial in the body of support that's available. So now I'm going to just focus briefly on issues specific to vets. I'm a psychiatrist, obviously this isn't my area, but from speaking to vets about what they feel is relevant and also reviewing the literature, I've just pulled together a few hypothesized contributors to suicide risk. And these bullet points here are drawn from 2 academic studies that I used earlier to illustrate to you what veterinary suicide rates are like in the US and in the UK. So Platt, who's an academic in the UK, Tomasi in the US, have suggested that the factors that we've heard again and again this morning in the presentations might contribute to suicide risk amongst people working in veterinary practices. And just to point out that obviously the first few bullet points on this list relate to issues at work, but they also noticed in the UK studies that a lot of vets who had died by suicide did have co-occurring life events. So they had problems mainly in relation to relationships outside work. So it's not all about the realm of work. So from talking to vets, it's apparent that there are a lot of other challenges that people are dealing with. So intense competition for jobs on graduation, interns surviving on very little finances, very poorly supported, very little regard for their mental health, sort of attitude of, you'll get on with it, which is very, very difficult. But this attitude, you've just got to get through it in order to progress to the next stage of your career. People have told me that television kind of super vets have made it very difficult for people to achieve what clients tend to imagine is achievable in terms of heroic surgical interventions for their animals. And these are the kind of things which make new graduates feel really less heroic than their peers might imagine. Again, we've heard about perfectionism and other personality traits in vets, and we've heard about the stigma of having a mental illness. And it's interesting what Rosie was saying, that in medicine we often hear about the inverse care law, so the people who need something most are the least likely to access it. So you can put as much support in as possible, but it seems that the people who need it are just not accessing it. And unless role models, I imagine, in veterinary medicine can model, looking after their mental health, being seen to access mental health in a preventive way. They don't need to kind of stand up there and tell people about their private mental health matters, but something about modeling a good work-life balance, not sending emails all weekend, being seen to take time out to look after themselves, seek help when they need it. I think those kind of role models are really important for new entries to the field. And obviously using helplines and other support that is made available. So what can people do within the profession to prevent suicide? And again, these are suggestions that I've taken from the academic literature. And these are very broad, quite obvious suggestions like better promotion of support services, formal support for recent graduates. And these are all exactly the suggestions that came out of your research, Rosie. I've mentioned improving attitudes towards work-life balance. So doing rather than just saying, we always hear people saying, oh, it's really important to have a work-life balance, but if you are sending emails at 2 a.m., you're really not modeling that. We've heard again about the importance of social networks and having a peer group. So for the last 10 years, I've had a peer group of registrars and now consultants, and we meet 6 monthly to talk about what we're finding difficult at work. We don't work in the same trust, so it's very easy for us to talk about things that we couldn't talk about within our organizations. We're very upfront about where we're struggling, and we all support each other, and there's absolutely no stigma of saying, look, I'm really, really struggling, because we're all trying to support each other to make the right career choices. And if that means saying to our peers, look, maybe this isn't for you, then that's fine. There's no shame in that. And we also heard earlier from Kate's presentation about coping and problem-solving skills, and also focusing on what people are very good at and reminding them of that. And sometimes it's helpful to have a mantra, repeating to yourself what you've achieved over the course of the last month, just to remind yourself that you can do good things. So in terms of what to do if a colleague may be suicidal, and this is very difficult because there is really no right response, and it'll depend on the personality and characteristics of that specific colleague. But obviously the first thing to do is to encourage them to seek help. And sometimes I will role play with people how you might have that conversation, because we're always telling people, talk about your mental health. But if you pluck up the courage to tell a colleague or a friend that you're really struggling, and they have absolutely no idea how to have that conversation and they shut it down, you will learn it's completely pointless to talk about your mental health. So I think we all need to have scripts of how we respond if someone tells us they're suicidal. And it might be along the lines of, well, obviously, it's really common to have, low mood or anxiety, and it sounds like you're struggling with that. So I'm, don't really know how I can best support you. So I'm pretending to be a non-professional here. Is there somewhere I can help you get some support? So can I help you phone up your GP? Can I help you access Samaritans? Is there a website we can look at together? So you're normalizing having mental health problems and also doing something about it. I often suggest to people who I've said, seek help, and I can see they're thinking, no way, I'm not going to phone anybody up, a couple of books. And, people who work in veterinary practices, they tend to be quite sort of bookish people who quite like a workbook to go through. It feels quite constructive, and I think often medics are similar to that. And so books like Mind Over Mood, where you take a cognitive behavioral approach, you work through scenarios, can be very helpful to break down the sort of unhelpful thought patterns that might be behind suicidal thoughts. And books like Overcoming Anxiety, Overcoming Low Mood are part of a whole series, and they are really, really helpful, so I recommend them. There's also some useful apps that have been suggested to me over the years. So Headspace is a very common one, and the British Medical Association advise all junior doctors to download that. Distract is a good app for people who self-harm, and Stay Alive has been recommended for people who struggle with suicidal thoughts. Practical issues in veterinary practices, and again, I would refer you to Rosie's article because she thinks through some really important issues to address here. I think on-call responsibilities come up repeatedly as something which really stress people out, particularly if you're by yourself, covering a huge area, a lot of remote working, and perhaps if you feel that one of your colleagues is feeling suicidal, it might be time to think together how you might share out that on-call responsibility. But of course, that has to be handled sensitively, as does access to the means of a suicide attempt, whether that's sharps or controlled drugs, because if somebody discloses they're feeling suicidal and the response is rather stigmatizing, oh, well, we'll shower at your on call, we'll limit your access to the means, that can be quite infantilizing, it can be very stigmatizing. So that has to be handled very, very carefully. And on my mental health ward, we practice what we call positive risk-taking. So we will not remove the means of suicide from somebody who is feeling actively suicidal, because we want to show them that we can trust them and support them to manage their suicidal thoughts without those kind of approaches. But again, that is going to have to be handled very sensitively on an individual basis. So what to do after somebody has died by suicide? And I think there are a lot of practical things to think about here, which again Rosie covers in her article. And the first thing is to think about how you break the news. Now, this is going to be very difficult. You don't know who in your client group, in your professional networks have already been affected by suicide. And I think it's very important to use the Samaritan's guidelines on the language we use when we're talking about suicide. So not using expressions like to commit suicide, not talking about a successful suicide attempt, and using the language that they would suggest. And also being accurate. You don't have to give too many details. It's commonly recommended not to state the method used, but not to obfuscate the issue so much that that will give rise to gossiping and information being spread inaccurately. It's important to offer support to all practice staff, because you really don't know who is going to be affected. You also don't know who had a particular friendship with somebody. We often talk about hidden relationships in suicide bereavement, and you just don't know who is going to need the most support. It's often helpful to arrange a reflective event, and in mental health services we always have what we call a debrief, which is a horrendous term because it almost sounds like everyone's getting together to decide who was to blame, who's going to be implicated in the the serious and untoward incident report. But the purpose of these events is to help people understand what happened and to think about what could be done to support people there. It's not an event to point the finger and decide who's to blame for this. So would also, thinking laterally, be important to think about key clients. And we heard earlier about particularly strong friendships that are formed with certain farmers, certain farming communities, certain individual clients. It's important to think about whether they might need particular support. And I would strongly recommend this publication, which is by Public Health England, which can be downloaded. And it would be important to have a good stack of these in the practice and certainly send them out in the mail to people who you know to have been affected by a suicide loss. It's a free download. You can order hard copies from Public Health England, and you can also use the link below just to download it online. And in that resource, there are information about national support groups like Survivors of Bereavement by Suicide, local support groups. Admittedly, geographical coverage is quite patchy, and also particular issues like how to deal with inquests, how to deal with media attention after a suicide. So I would strongly recommend that. And that was a co-produced resource, which was led on by people bereaved by suicide. Another resource I would recommend is another co-produced resource that we did using the interviews that we did, the 27 interviews we did, where we asked people, and I was doing the interviews, and I would say to each interviewee, if I was bereaved by suicide by one of my colleagues, if they were to die by suicide, what would you suggest that I would do? How could I support my colleagues? What would I need to do? And we took their suggestions and we put them together into this resource called Finding the Words. And this again is a free download. You can get hard copies if you want a bulk order of hard copies for free. Let me know and I can get them sent to you. But you can also download it for free from this link. And this is a sort of guide to not being really socially awkward, essentially. It's a way to break the ice, offer to support somebody who's been bereaved by suicide. And it gives you tips on how to act normally with them, do the kind of things you'd always want to do so that they don't feel stigmatized and they are aware that you're there if you need them. And even if they never take up the offer of support you've given them, the latent support is there. So a couple of questions to really think about and take back to your your practice is whether you are aware of support systems locally. Is there a local branch of survivors of bereavement by suicide? Have you ordered a stash of helpers at hand for your practice? Have you put a few copies of Finding the Words in your practice? Because they're kind of life resources for any member of the community. They're a sort of citizen's guide to how to be a good person. Do you have access to an employee assistance program? I know from Rebecca's presentation that came quite low down the list of resources that people used, but it's still important to have that available because of the anonymity afforded by that. And also, are managers and seniors open to discussion about mental illness? And I've heard stories about people who've been off with mental health problems, come back, and all their managers said is, "Oh, you back then? You dealt with that problem then?" And this sort of trivial, slightly flippant attitude to mental health problems is really not helpful for people. So any questions either now or afterwards in the lunch break, I'll be delighted to talk to you about it. Thank you.